We have a 73-year-old gentleman here with BPH and urinary retention. He has been on Flomax and finasteride for many years. However, his lower uterine tract symptoms have worsened in the past 6 months significantly since November. His symptoms include weak to moderate stream, nocturia, frequency, every few hours, some urgency, hesitancy, straining. He has no gross hematuria, and he does have a history of a UTI that has been treated with antibiotics in the past. However, recently he was supposed to undergo a cornea surgery for which Max was discontinued temporarily, and during that time he went into acute urinary retention and had to get a Foley catheter placed, and has failed multiple trial avoids since then. His other past medical history and surgical history include BPH, glaucoma, macular degeneration, and inguinal hernia repair. Next slide. His adjusted PSA back in February was 6.02, which was slightly increased since 2017, which was 5.24 back then. He also has had 2 prior negative prostate biopsies for the elevated PSA at that time. He had a renal ultrasound back in November, which demonstrated marked thickening and mural trabeculations of the urinary bladder wall with diverticula. He had a post-void residual at that time of 354 milliliters. Prior to the urinary catheter placement, his IPSS score was 25. He had a QOL of 2 and a SHIM score of 6. Next slide. He most recently underwent an MRI prostate, which demonstrated that his prostate volume was approximately 150 cc's, and there were no focal lesions.
All right, so we sort of just got started here because I think the radial axis was pretty straightforward. The first run that we did in the iliac artery, a little bit of an angulation, but it wasn't too challenging to get down, and that's one of the advantages of doing this technique as opposed to up and over, particularly in these aortic bifurcations that are steep. And then we did a little off here to look at the iliac and the internal iliac branches, and then we have a DSA run, which is coming up here. See, so not a challenging case from from an anatomic perspective, but I wanted to show you guys what we have set up right now. So if we can zoom in on the wrist, that would be great. Can you guys see the wrist? Yeah, there we go. All right, so in the wrist we have a 5 French prelude ideal sheath, and then through that we have a 130 penumbra select burn shape, and we have a flow 30 TUI, which doesn't have a side port, giving us a lot of room for our microcatheter. The microcatheter that we chose today is the 150 centimeter embolic microcatheter, which we're going to probably talk about when we get started here. I know there's a lot of people that want to comment, but let's start off with the anatomy here. I think this is pretty straightforward. Let's show the live feed, and let's put a smart mask up there. Good. I got it. Okay. Beautiful. We see very clearly on this image the pudendal, the superior vesicular. I don't see an obturator on this image. Do you guys see it? Anybody?
I don't see it.
Okay. So we're lucky. We have a nice big artery. You can see there's branches to the median lobe, which I think in this case is going to be probably the most important thing, that we get a lot of embolic into that.
So we haven't done a lot of radial case. I think it's a nice approach. My comment in this case, it looks like type 4 prostatic artery. Can you hear me?
Yeah, I can hear you.
Yeah, so it looks like a type 4. The prostatic artery is arising from the internal pudendal artery. It's a big prostate, 150. So one comment is, once we don't see the obturator artery in this arteriogram, it is really important to understand and use cone beam CT. I think you use cone beam CT to identify if you have any other additional branch. So once you catheterize this artery, would it be important to understand all the feeding branches that you could have in the prostate?
So Jeremy just cannulated. It looks like the trunk here. We're going to take we're going to do a quick picture and see where we're at and what branches are coming off, see if there's any rectal branches. So what we're going to do now is we're going to do a run with the balloon down, then we're going to put the balloon up, and we're going to see if we can get a change in flow. So Jeremy's going to inject, the way that we always inject in the prostate, and this is the way that Francisco sort of taught us 7 years ago, is to go very slow in the beginning, try to capture the flow in the vessel, and then more aggressive sort of at the end of the injection to see the collateralization. This looks like a perfect spot, though, so we'll see what we pick up here. I would be totally fine embolizing from here without the balloon up, and so sometimes what I'll do is I'll inject a few cc's of particles, then inflate the balloon. And so, Francisco, in my mind, the balloon catheter sort of helps guide the embolization in more of a perfected technique without actually having to move the catheter distal, because you can do what you described as proximal first and then distal. And so the distal is sort of similar to what the effect that you get with the balloon inflated. So we'll see if it changes, and then we can always take the balloon back down and then start embolizing. Well, I typically use the same particle size because at the end of the cases I've been, with the balloon, I don't think that there's really that much need to switch. If I have a straight end-hole microcatheter, I may use the 250s. If I go more distal, for example, I don't want to get non-target with the smaller particles. But I think when you have a very good balloon occlusion, like we do in this case, I think it's pretty safe to use these particles, assuming we're watching for collateralization, which we're doing, as we're injecting, obviously. What do you guys think now? I mean, that to me looks like all prostate, but then you start to see the collaterals at the end there.
Yeah.
Hey, Ari and Aaron, do you guys think that, just out of curiosity, when you didn't have your balloon up, you had much better glandular perfusion? So are you embolizing, Aaron, with the balloon up or down?
Right now, it is up, but I agree with you. So what I do in a lot of these cases is I'll start the embolization with the balloon down, sort of like a modified perfected technique, and then when I start to see some reflux, then I'll inflate the balloon. But I really don't see. I mean, it took a lot of injection to get the collaterals to fill here, and so I still feel very comfortable embolizing in this spot, even with the balloon up. But I've used this balloon quite a bit, so I sort of know how it behaves. But I think if you haven't used it a lot, you probably should start with it down for a bit and then inflate it towards the end. Unless you're trying to reverse a pudendal collateral, and then you obviously have to leave it up the whole time. You who are just joining us, we're on the right prostatic artery. We finished the left. We did about 8 cc's of 100 embozine. Before we do this run, I'm going to show you the last few runs. And then we put in 2 Terumo CX coils, one 2x6, and then another 2x6.
3x8.
Oh, 3x8. So I'm going to show you guys that's the final run on that side after the coil. We had a little bit of an acute angle, the internal iliac on this side, but again, I think the radial access gives us an advantage when we're trying to cannulate these angles. You can see here we were a little more distal, then we pulled back. And there's the angle right there. We just used a glide wire, and we got down into the internal iliac. Actually, no, we didn't use a glide wire. Let me show you what we did use. We tried a glide wire. That didn't work. So then we used this is a fathom wire. So I took the fathom wire out of the microcatheter, and I put a really big curve on it. And I find this works quite well. And you can sometimes track the 4 French catheter over the fathom, and then that way you have easy access without having to use an 035 stiffer wire. And sometimes that flops better than, let's say, like a Benson, for example. But very similar to the other side, we have a very, very easy to identify prostatic artery at the end. But I'd like you guys to see how we do spin radial, because I think it's important for prostate, because this can be very challenging. It could be the hardest part of the procedure, especially in tall patients. So if we look at the way that the II is angulated here, it's in a propeller trajectory. As we're injecting the embolic here, we can talk. We're going to go back to a little bit more AP. But if it reaches the pelvis, which it can, we can do a full spin. And I will use spins if I'm confused. I use EmboGuide quite a bit. I think it's very important for people that don't have a lot of prostate experience to use cone beam CT in almost every case. Art and I have a lot of experience doing these together and individually, so we feel very comfortable not using it in some cases. But I like to use it at the end using a non-contrast, because I do like to look for non-target embolization, and you can get a good sense of how well you perfused the prostate with beads. Sometimes you see more beads in the median lobe or less, for example, and you can some ways predict response that way. I also look for beads in the seminal vesicles to predict complications the patient may have. Beads in the rectum, for example, even in the penile branches. We don't like to see that, but if you do identify it, you may be able to counsel the patient as to what they may experience postoperatively. We're going to put a coil in here to occlude the artery. This is a Terumo CX coil. This is what size is this? This is a 2.4. 2.4. We're going to put this in to finish off, and then we'll go over how we exit out of the artery in a second. You know, this is we're distal to that capsular branch here, so we're going to drop the coil here. We're not coiling a collateral. This is the main prostatic artery, and so this is something that we've been debating and looking at over the last few months. Art loves this technique.
To be clear, you're going to coil the main prostatic artery on the way out.
To be very clear, that's exactly what we're going to do.
So, so just off the cuff, granted I'm about to scrub into a case too, but I find this a little bit atypical, let's say, to say the least. Couple reasons why. One is, I would say in our experience, we probably repeat about 10% of PAEs. And if you look at the Portuguese experience, it's roughly about 10% in their experience as well, when these patients are followed very closely. And repeat embolizations have a very high success rate, and oftentimes we'll go back into that native artery to perform embolization. Not always, but oftentimes. And in performing a permanent coil embolization, obviously you will be caging yourself out from that vessel in future. And when you have to go back via umbilical collaterals or internal pudendal collaterals, or I've gone back through, as you know, IMA collaterals, it is a complete pain in the neck. And so I don't really see the need. I think that if there was a need to say, I'm worried about, am I getting a truly embolic enough effect to cause an infarction, I would make the argument to use something like myself and Ari, I'm speak for him because I know he's scrubbed too, is one of these gel foam pastes. So just make your own gel foam paste. It acts like a 1 to 2 millimeter particle through a 1 cc medallion, and you get a nice sort of like a temporary glue effect. I guess for me, I don't really see the point of coiling. Could you maybe expand on why?
Yeah, Sonny, I don't disagree with you. I don't do this in every case. This is something that we've talked about quite a bit. I think my repeat numbers are not high, so I'm not that worried about it when I do it. And I think if you're gonna get recurrent symptoms, it probably will be through the collaterals and not through the main prostatic artery. But I've seen both, so it's hard to say. I mean, obviously there's no data to support this. We know that. We wanted to show this just because we've been debating whether this is something that we should or should not be doing, but we do it, and that's why we're talking about it. But I 100% agree with you. Art thinks that this may be. Well, you could talk about it. This may create a situation where we can get the catheter out sooner.
I think it really just helps the catheter out sooner, and I try not to repeat. If this guy fails, I would do a resume treatment or something else to offer him those opportunities. I mean, the struggle to go back to do a repeat PAE, I think it's a great first step. I can tell you that as a guy, if I had BPH, this is the first thing I would do. I have patients with prostate cancer that we do focal treatments of the tumor that have 180-gram prostates. These people have been relegated to only prostatectomy. Now we can treat the spot, and then I embolize them about a month later after we treat their cancer. So I think there's a lot of opportunities. I just think stopping the pressure head helps their symptoms resolve a little quicker, and we can get the catheter out sooner.
So Jeremy just released the coil with what we call the pickle. You guys can see it here, the green pickle. And so now we're gonna finish up. Now, can we get the arm up to do a spin? So we're going to check the lateral. If you want to zoom out a little bit, we can see we're tucking the arm in. We're going to check the lateral. This is a very easy spin to do radial. We do this with all our radial cases. It is a little more challenging when we do prostate, obviously, because we have to put the patient's head right up against the C-arm. We're going to center it a little bit. I think we were able to show you guys the 3D screen coming up after we do the scan, which is going to be on the 3D workstation. And I want to just roll through it really quickly for you, just so you can see what I look for on the non-contrast cone beam CT. Again, we talked about to be able to predict potential non-target. I don't think we're going to have any, but we always want to look. The other option that with a non-contrast cone beam is you can just do it at the end after you take the sheath out if you want. I mean, I love using non-contrast cone beam CT. I'm probably the only one, but I like being able to do this at the end of the case. So we're all set to go here. We show the 3D screen.
Did we inject?
No, non-con.
Oh.
Can you guys see the 3D screen or no?
Yes.
So
we can all see it, Aaron.
You can see it. So very commonly, when we do the second side, the contrast is already washed out. Well, not completely, but you can see the other side still has some retained contrast. I'm looking very closely for non-target. I don't see any. We have a lot of, we can definitely see some contrast in the median lobe there. And so this looks like a great embolization. So we're done. We don't want the catheter flicking any of the vessels on the way out. So we remove it with the wire in place like that. Very simple thing to do. Every radial case, we do it that way. And now we're going to show you guys the band real quick. Can you guys see my finger? Yeah. Anywhere, so I don't think the styloid is a good place to access. The best place to access in general is about an inch above the styloid or so. This is about 1.5 inches above that. So this is probably about as high as I would go. We had let's show the other band for a second. I have a regular size. This is the Merit Prelude.
We might need a large.
Yeah,
large
but this is medium.
Oh, that's not going to.
And so this isn't going to fit. This is a large TR, which I think will work well. And so we're going to put that right. Jeremy knows where he punctured. It's going to be right over the puncture site, not the entry into the artery itself, or into the skin itself. It's always over the arteriotomy. And so with a higher up puncture, you got to be very careful how you place the band. If you place it over the sheath, you're probably going to get a hematoma. So it's a subtle point, but I think it's really important to see how to close these high punctures. In terms of the type of band, all the bands are good. I think we'll show later, we'll show a distal access, hopefully when Darren's here. You have to really use two different, I like the Prelude Sync distal or the Vasostat. Those are the two options for that. Any other questions before we wrap up? We're done with the PAE.
Hey, Aaron, I came back as you were talking about taking out the catheter